Good afternoon, everyone, and welcome. My name is Ruby Rose Lawler, and I am the Executive Director of Youth Rise, and I will be moderator of today's side event, which is co-organized by the Global Commission on Drug Policy. So Youth Rise is a global network of young people with lived and living experience of drug use, and young people otherwise disproportionately impacted by drug policies. We empower young people to engage meaningfully in advocacy for health, human rights, and policies that reflect their realities. Founded in 2006, we turned 20 this year, Youth Rise was established in response to the lack of youth representation in drug policy and harm reduction discussions. Since our inception, we have played a pivotal role in mobilizing youth participation at key international, regional, and national advocacy platforms. We develop research, tools, and resources to support these efforts, while also delivering impactful training sessions worldwide to build the capacity of young people to advocate for evidence-based drug policies. Youth Rise is recognized as a global leader in ensuring that marginalized youth have a seat at the table in decision-making processes that affect their lives. So, as you can see in this slide behind me, which isn't there, we have a long list of co-sponsors. I'm not going to get into the long list. I think it would take me a full minute of my 5 minutes I have. But we are especially grateful to all of them for making this conversation possible and for their continued commitment to youth-centered, rights-based approaches. So thank you. Your support helps ensure that the expertise and lived experience of young people, particularly those most marginalized, are heard within the formal spaces of the Commission on Narcotic Drugs. Today, on the 9th of March, the Human Rights Council in Geneva is observing the annual Day of the Rights of the Child, with a focus on the human rights violations of children in armed conflict. This parallel discussion underscores how children and young people's rights must be at the center of every area of UN work, including drug policy and health systems, and reminds us that young people are often navigating multiple overlapping crises and forms of violence. In this complex environment, listening to the experiences of young people is imperative. In 2024 in New York, member states adopted the Pact for the Future and the Declaration of Future Generations, and have pledged to protect the rights of all young people while including them in policy decisions. This means young people who use drugs and young people otherwise impacted by punitive drug policies too. As part of a project led by the Global Commission on Drug Policy, Youth Rise conducted consultations with young people in diverse regions to understand how drug policies are shaping their lives, rights, and access to care. Based on this process, young people consistently stressed 3 points. 1, services are often unavailable or unsuitable for them. 2, punitive approaches deepen stigma, fear, and exclusion rather than supporting their health and well-being. And 3, that youth want to be meaningfully involved in the design, implementation, and evaluation of the policies that impact them. So what does it look like when services are truly youth-friendly, rights-based, and grounded in the realities of young people's lives? And how can we build comprehensive care systems that take into consideration the experiences of young professionals, meaning young peers, young service providers, young doctors, young researchers, and advocates in harm reduction, prevention, and treatment? Today's side event aims to explore these questions. I'm very happy to welcome the distinguished speakers joining us today, and I thank you for being part of this discussion. To start our panel, it is my pleasure to invite Commissioner Adiba Kamarul-Zaman from the Global Commission on Drug Policy to deliver opening remarks via a pre-recorded video message. Thank you.
Distinguished guests, colleagues, and friends, good afternoon. My name is Adiba Kamarul-Zaman, and I am a member of the Global Commission on Drug Policy. I've also recently been appointed by the UN Secretary General to serve on the independent expert panel tasked with evaluating the international drug control architecture and providing actionable recommendations to the Commission on Narcotic Drugs. Before we begin, I would like to thank all the co-sponsors of this event and my sincere appreciation to our co-organizers, Youth Rise. They have been a valued partner in our work, examining the effects of drug policies on children and young people. This work will culminate in a policy brief to be released next month, elements of which I will touch on today. Resolution 68/6, which established the independent expert panel, calls for consultations with a broad range of stakeholders, civil society, academia, youth groups, the private sector, and others. The speakers here today reflect that vision: youth, frontline service providers, clinicians, researchers, and advocates. Their perspectives are essential, and this inclusive approach remains central to our work. Young people on the front lines of care, service delivery, research, and advocacy witness daily where policies succeed and where they fail. Their experiences are not peripheral. They are fundamental to this discussion. Through this project, we are working to understand how drug policies affect children and young people and to turn that understanding into meaningful action. We do this first by linking international human rights frameworks, including the Convention on the Rights of the Child, to domestic policy. We also conduct consultations with a wide range of stakeholders and, crucially, with children and young people themselves to ensure their perspectives guide our work. At the same time, we develop actionable, evidence-based recommendations, and we work to elevate these issues on political agendas while encouraging further research. From our consultations and research, several key messages stand out. While preventing or delaying drug use is widely recognized as important, it often overshadows the more hidden harms created by laws and policies regulating drugs. Secondly, punitive approaches can extend surveillance and coercion into spaces that should be protective, such as schools, clinics, and residential institutions. Thirdly, children who use drugs are often denied essential health services due to age restrictions, stigma, or lack of youth-specific programs. Law enforcement disproportionately affects minority and indigenous communities. And lastly, aggressive drug control strategies, including militarized crackdowns and eradication campaigns, can put children at risk of displacement, exposure to harmful chemicals, and violence. Now, despite these challenges, there is reason for optimism. Evidence-based, health-centered approaches, including harm reduction education, community programs, and expanded access to services have demonstrated positive outcomes for prevention and well-being. As member states reflect on 10 years since the UNGASS on drugs, which incidentally carried the slogan, "A better tomorrow for today's youth," we must ask, was this merely a slogan, or has it really guided meaningful action? By centering the voices of children and young people and ensuring their meaningful participation, we can turn commitments and slogans into action, creating a truly better tomorrow for today's youth. Thank you, and please do keep an eye out for our policy brief, which we hope to launch next month.
Thank you, Commissioner Adiba. I now invite Dr. Annette Binder to take the floor. Dr. Binder is a physician at the University Hospital Tübingen at the German Center for Mental Health, as well as a member of the UNODC Young Doctors Network, working at the intersection of clinical practice, mental health, and drug policy. Over to you.
Yeah, thank you so much for inviting me to this panel today. And I would also like start by thanking you, RISE, for organizing this side event and the co-sponsors for supporting this important topic. Today I want to talk about a topic that is often overlooked in drug policy discussions: children and families of people with opioid use disorder. When parents have access to effective, evidence-based treatment, including opioid agonist treatment, the benefits extend far beyond the individual. Today, I would like to show why improving access to these treatments is not only a health intervention, but also an important step to strengthening families. Opioid use disorder is widely understood as a chronic and treatable health condition. It is associated with high mortality and strong social vulnerability. Opioid agonist treatment, such as methadone or buprenorphine, is the most evidence-based treatment we currently have. Decades of research have shown that it reduces mortality, decreases illicit opiate use, and improves both mental and physical health. Importantly, it can create stability in people's lives. And stability is essential for recovery, including participation in family and community lives. And recovery does not always mean abstinence, especially in opioid agonist treatment. Recovery means stability, health, and the ability to live meaningful lives. However, despite strong evidence, stigma still shapes how treatments are perceived by society, institutions, and sometimes even by the patients themselves. Stigma operates at several levels. Thank you. We see it in public attitudes, in healthcare systems, and also as internalized stigma experienced by the patients. These dynamics directly affect treatment outcomes. People may delay accessing care, discontinue treatment too early, or feel pressure to stop treatment even when it's helping them. So stigma does not only influence perceptions, it can actively destabilize recovery. In a qualitative study we conducted in 2 injectable opioid agonist treatment facilities in Germany, we interviewed 27 patients about their experience. Patients consistently described treatment as stabilizing and life-changing. However, many also perceived it as a last resort treatment, and some still felt that true recovery should mean abstinence. We described this dynamic as recovery at risk. People benefit from treatment, but stigma can make them question whether they should discontinue. These dynamics become especially important when people in treatment are parents. One patient told us, "I have a daughter. I want to be a role model again, not a bad role model." His wish to stop treatment was not driven by lack of benefit, but self-stigma, and the feeling that staying in treatment conflicts with being seen as a good father. If stigma can destabilize recovery, the question becomes how can health care systems actively protect or enable stability? One opportunity is rehabilitation. In Germany, specialized rehabilitation for substance use disorder is widely accessible through healthcare insurance or pension insurance systems. Historically, these programs followed a strict abstinence-based model, and patients receiving opioid agonist treatment were excluded. This changed in the recent years. Today, rehabilitation can take place when patients continue their opioid agonist treatment. This reflects an important shift. Pharmacological stability can support treatment rather than undermine it. I would briefly illustrate this with a clinical example from my work. A patient now in her mid-30s developed a substance use disorder at the age of 16 after significant psychosocial stress, including the loss of her father. At 18, she started opioid agonist treatment, the earliest possible in Germany. Later, she had a son, but due to ongoing instability, the child mainly lived with the grandmother. She maintained contact but struggled to consistently fulfill her parental role. During an 18 weeks rehabilitation program, she continued her opioid agonist treatment while receiving intensive psychosocial therapy. Structured weekend visits with her son were integrated into the treatment, and over the time we observed improvements in emotional stability and social functioning. This led to a stronger mother-child relationship and a great emotional security for the child. This example shows how integrated evidence-based care can interrupt intergenerational vulnerability rather than reinforce it. Reducing stigma also requires professional responsibility. In Germany, several professional societies have joined forces through the initiative Open Hearts, Open Minds. This initiative promotes awareness and concrete strategies to reduce stigma towards people with substance use disorder, also within the healthcare system. And I brought you a picture of a school for young healthcare professionals working on this topic. And this is so important because stigma does not only is a societal task, but it must also begin within our healthcare system. If you want to learn more about the initiative, you can scan the QR code, but unfortunately the webpage is only in German. Taken together, these findings point to 4 policy implications. First, we have to ensure access to evidence-based opioid agonist treatment. Second, we should include pharmacological therapy and rehabilitation. Third, we should work on reducing stigma also within the healthcare system. And finally, opioid agonist treatment should be recognized as an intergenerational prevention strategy because stabilizing parents ultimately protects children. In conclusion, evidence-based opioid agonist treatment can create stability, but stigma can undermine this. When parents receive integrated, destigmatized care, recovery becomes more than a symptom reduction. It becomes a foundation for family stability and child well-being. In this sense, evidence-based addiction treatment is not only a medical intervention, it is also a family and youth policy measure. Because when parents stabilize, children thrive. Thank you very much for your attention.
Thank you so much, Dr. Winder, for highlighting that destigmatization and ensuring access to, as you said, evidence-based opioid agonist treatment is not only a clinical issue, but also a youth protection and intergenerational prevention strategy. So I now invite Clara Halsinger. Clara is a counselor with Check It, Vienna, which is a peer-based prevention, harm reduction, drug checking, and counseling service housed in this very city. Over to you.
Yes, I also want to start by saying thank you for organizing this side event and for having me. In this presentation, I will present to you Check It Peers, which is the peer project that we have here in Vienna. And yes, my name is Clara Holzinger. I am a social worker. I work at Check It, which is the organization that Check It Peers stems from. But I'm also a former peer, so I was a peer for 2 years. So I bring a little bit of expertise about this issue. Okay, so first I will quickly tell you what my presentation will cover. First of all, I will give a quick introduction into what Check It is, and then I will tell you about our project Check It Peers. Then I will go into the advantages of peer-led work in the field of harm reduction, and I will also talk about the barriers we face with our peer-led project at Check It, but also other peer-led projects face. And then I will go into a quick summary. So here I brought a picture of our peer team. Here you can see the peers, but as I said, first I want to give a quick introduction into what CHECIT is. So CHECIT is an addiction prevention organization from the Suchthilfe Wien, which is the biggest institution for addiction care in Vienna. And at CHECIT we offer drug checking, counseling, and information about anything regarding harm reduction and safer use. And then CHECIT Peers is a branch of CHECIT that is aimed at outreach work in public spaces and is aimed at young people who use substances or alcohol recreationally. So as I said, the team, you can see it on the in the picture, is a team of 18 to 30-year-old people who went through a training period before they started to work as peers. So at CHECIT they get a very extensive training into what addiction prevention and harm reduction is like before they start to work as a peer. And then, as I said, this project is aimed at doing outreach in public spaces or at events that are directed at young people. And there they offer, the peers offer short consumption reflections or short consultations, or they can immediately, or they can connect them to CHECIT or other organizations if that is needed. So now I will get into the advantages of peer-led harm reduction services. So there are not only advantages for service users, but also for institutions that offer these kinds of projects. So I will first tell you about advantages for service users. So as I said, this is a very low threshold approach. So this outreach work is a very low threshold approach, and it's about meeting young people where they are, not only locally, but also in their reality, in their lifestyle. And approaching them as peers builds up trust more than maybe if an older person who looks very professional would approach them. And it creates identification, and it makes it easier to talk about certain things maybe. It's about flattening institutional and educational hierarchies with peer-to-peer education, and it's about making education more informal and making it more fun so that people can take more information away with them. It also might be the first encounter that these young people have with a healthcare organization. So if it makes a good impression, then maybe if later in life there comes a point when they will have to when they have more problems with addiction or other healthcare issues, then the barrier to approach an institution will be lowered because they have a good experience with the CHECIT peer, for example. And now, as I said, I will get into the advantages that institutions have from peer projects. So first of all, it establishes credibility with the group that the institution or our institution, for example, wants to reach, and it ultimately brings us closer to the group we want to reach. Peers can also be used as a resource for institutions to gather information about young people, about which clubs are important for young people right now, where they meet, what kind of substances they consume, so that they can bring it back to the institution, and then the services of the institutions can stay relevant. So ultimately, it's a knowledge transfer of peers bringing out and spreading information, but also bringing information back to the institution. Now I will get into the challenges that we face with our peer project. So, as I said, the peers at CHECIT go through a training period, and it's very professionalized, which is a good means for quality control, but it also means that it's not available to every young person to become a peer themselves, because they need this time to do the training before they can start the job. Which means that our group of peers is pretty homogeneous. It's mostly students from social work or from psychology doing this kind of work, and we would love it if it was a little bit more diverse, but this professionalization kind of inhibits this sort of participation of everyone. And then also funding. We are lucky enough to have a funded peer project. This is not the case everywhere. A lot of peer projects in the field of harm reduction, for example, are grassroots organizations, and it is just very important to ensure funding so that quality control can happen and that these projects work as well as they can. Okay, and then I will come to the summary. So as I said, there are a lot of advantages, not only for the service users, but also for institutions, if institutions have peer projects in this field. But there are still a lot of challenges, and it's not funded a lot of places in the world. And now all of these points were very theoretical, but because I was a peer myself, I also wanted to bring a little bit of my experience into this, and just also tell you about that this kind of work actually works very well. In my experience, it's very easy to talk to people, to get information out there, to have little talks, to get young people connected to professionals. It just works very well. So yes, I'm very happy that we have this project and that I can speak to you about it today. And that was it.
Thank you so much, Clara, for showing how peer projects like Check It make services more accessible and trustworthy for young people, as we've just heard, and for underlining why sustainable support for peer work is essential and can integrate both prevention and harm reduction efforts. So I now invite our final speaker, Vincentius Asvian, who is a program manager at Inti Muda Indonesia and a member of the International Working Group of Youth Rise.
Thank you. Good afternoon. My name is Vincentius Asvian. You may please just call me Asvian. Previously, I want to say thank you to Youth Rise and Global Commission of Drug Policy for co-organizing this event. I'm one of the international working group from Youth Rise as well, representing Indonesia from the ASEAN Pacific region. So this is my presentations regarding the youth center programs on harm reductions and drug policy reforms. I came from Inti Muda Indonesia, organizations working on HIV, young key populations, and also harm reductions in Indonesia, mainly for young people under 35 years old. Okay, so for contextual, this is contextual informations. I want to start with a number like there's 280 million people in Indonesia. That is the fourth largest country in this planet, and within that number sits one of the world's youngest, fastest growing demographics. And when we talk about drug policy in Indonesia, we're not talking about a small experiment, but we're talking about decisions that shape really when it comes to health, freedom, and futures, and it starts from policy. Next. This is the first one is about the impact of drug policies on youth-centered service in Indonesia. This is the legal reality. Indonesia operates one of the most punitive drug frameworks in the world. Possessions alone carries 4 to 12 years in prison. Trafficking can mean life or death. There is law on the books, Supreme Court Circular Number 4 of 2010, that is supposed to direct people who use drugs towards the rehabilitation rather than incarcerations, but in theory, small quantities should open the door to treatment. But in practice, the door is almost never open. And also, 40%, as you can see in the screen, 40% of people charged with drug trafficking offenses were carrying quantities officially considered below 1 day of personal use. They were not traffickers, but they were users, and they were prosecuted as criminals. Among all those charged specifically under the personal use article, the one designed to protect them, 92.3% were still sentenced to prison only, no rehabilitations, just punishment. As you can see on the next slide. But this is the contradictive sides in Indonesia when it comes to drug policies. What Indonesia is, besides of the full punitive countries, we are also a country that is having this kind of mandatory rehabilitations on paper. But in reality, you can see that among those charged specifically under the personal use, 92.3% I said is sentenced to prison only. Like there's still a huge amount of person, especially young people, who are not direct to the healthcare services, which is rehabilitations. But it's also contradictory to, I think UNODC several years ago published a report that only 12%, around 12% of drug usage that is affecting health. So it's kind of a problem. That is why Indonesia make it a full punitive and also mandatory rehabilitations for drug use in this country. Next slide. This is the policies on children and youth, and we look at the children specifically. Out of 47 child cases handled by prosecutors between 2020 and 2025, 40 were detained, and also despite a legal framework that says detention should be the last resort. This is not a justice system, I think, that protecting young people, but it is a system that is actually criminalizing them. Next. Okay, so in Indonesia, especially as a part of International Working Group in Timur Indonesia, we are work on, this is very specific topic when it comes to work on age consents. I think when we speak about young people, the most specific aspect or background that we can see is the number, the age background. So we can say, okay, the young people is between 18 to 24 or 18 to 35, but in Indonesia, there is this kind of specific problem when it comes to child who use drugs or even young people who use drugs under 18 years old. So we are working this specifically on age consent. Young people cannot access care without parental consent. That's what happened in Indonesia when it comes to HIV services, testing, ARV, and also especially on the harm reductions like opioid agnostic services like methadone and Subuxone in Puskesmas in a health center in Indonesia. And we're working on it, for example, like for the teenager who uses drugs, is living with HIV or needs harm reduction support, going home to ask parents permission is not just impractical. It can be dangerous. It can mean exposure, rejection, or even violence. And we work on that when it comes to age consent. And this is like one of the practices that we do in Indonesia. When it comes to HIV response, we work not under, it's supported by the Global Fund. And this we have some mechanism of community healthcare worker to outreach those key population, especially young people who are high risk to HIV and also who are using drugs to access the harm reduction services. So the work on age consents, we encourage the government to be able to recognize, to be able to work with them, the community's healthcare services, especially those young people who are also using drugs and working as a community healthcare worker, to be able to assign as a guidance, as a guardians, to tackle these works on this problem on age consent. The next one, this is the community-led monitoring. This is specifically on HIV, but when it comes to the services, the opioid agnostic services also monitored under this mechanism. So actually, community-led monitoring is a mechanism built by the community to support the healthcare services to improve their service quality by data, by recommendations, and an analysis when it comes to the problem that is happened or occurred in the field. And also, services are assessed based on 5 key indicators: their availability, accessibility, affordability, acceptability, and quality. When we think about harm reduction services in the clinics, in the healthcare services in Puskesmas in Indonesia, for example, I will say again, like opioid services, like methadone services, Subuxone, and services, young people who are accessing the services and they experiencing a lot of problems, for example, like stigma, discrimination, even they be unable to get into the clinics because of those age consents, how we be able to tackle the situations by data, obviously, like, right? But this is the information that be able to also cover the needs of the data, the community-led monitoring. We have this intervention in Indonesia, and we emphasizing on how we be able to do the age disaggregation on data, on the community-led monitoring, to see which services that is affecting young people, which services, which city, which province on the harm reduction services that is really focusing on there is obstacle occur on the young people who use drugs, on young people who are key populations. And also, next slide, please. I think I want to, I have mentioned like the challenges working on harm reduction, working on the advocacy, the research on young people, on the community. it's so unique because harmful and normative culture towards harm reductions is a huge thing in Indonesia. It's the drug itself, the perception toward the drug itself is not necessarily through the policy, but through the culture. It's directly to punishment, to the jail, anything. But it's less of health approach. The second one is obviously I want to say about the funding cuts and also shrinking civil society spaces in Indonesia, especially young people organizations and also organizations of people who use drugs facing a really, really huge problem when it comes to these situations, and also stigma discrimination within the health system itself. And under 18 years old, harm reduction still treated as a controversial that I mentioned earlier when it comes to age consent and lack of age disaggregated data. I think when it comes to data, this is the thing that we in Indonesia always fight in. Okay, we need to do age disaggregation data so we'll be able to have data to advocacy, to be able to have this recommendation for policy, for a policy that is actually more friendly to us, to young people. But there are some kind of best practices, I would say. The first one is health-based, non-punitive approach. This is what we know what works, a health-based, a non-punitive approach, with treating drugs use as a public health issue, not a criminal one that is a foundation. Everything else builds on that. And peer-led outreach services reach young people that formal health system, and also young people trust other young people. It's like a peer support workers that are not a nice addition to a program. That is a nice addition to a program. They're often the program. And also the training health workers to be youth-friendly. And the last one is the thing that I want to highlight from UTRES. We have this publication called Full Spectrum Harm Reduction Approach. It's some kind of a gate for everyone to be able to see how is young people, how is harm reduction be able to we perceive when it comes to speaking on young people. What is the full spectrum? What is the needs of harm reductions when it comes to young people? I think this is some kind of a really best practice that you guys can see and you guys can learn when it comes to what interventions that is needed the best for young people. You can see in the publication. So those are challenges. Those are the best practices and also the thing that we did in UTRES in Indonesia when it comes to youth center program on harm reduction and drug reform intervention. And I think next one, I have this kind of recommendations for organization and also for the government. I want to mention when it comes to the government first, it's really important when it comes to the community, let them lead, not just like to participate, but to let them lead when it comes to interventions, and please invest in more specific, that I will say again, disaggregated data on young people in every variable of kind of work that you do, and create also accountability mechanism that involve communities, for example, like CLM itself. And the last one is invest in communities directly for their sustainability. And last but not least, for organizations, to the peers, please always, it's really important for us to target the specific strategic areas. For example, like in Indonesia, in Inti Muda Indonesia, we work like directly every day to support, like to intervene the Global Fund supported program, because when we already know where is the strategic ones, the impact's gonna be strategic, the impact's gonna be abroad as well. The second one is us also invest in community strengthening, especially regeneration to the younger generations, because when it comes to young people, and when we're speaking about how young people be able to engage in all this harm reduction process, we need to invest as well to the younger generations when it comes to regenerations. And the last one is how I'm doing here with UTRES through International Working Group, work through coalition and consortium to join utilize data programs and also resources. So I think that's all from me. Thank you so much.
Thank you so much, Asvian, for bringing the perspectives of young key populations and reminding us that the law, policy, and stigma interact to shape what is and what is not possible in youth-centered programming. We really appreciate it. So now I'm going to open the floor for brief remarks from our UN agency, civil society, and member states that have supported this event. Each intervention should be around 2 minutes, if possible. We invite you to reflect on one concrete way in which your institution is supporting youth-centered, health-led, and rights-based responses to drug-related challenges. And one priority change you would like to see in the international drug control system to better protect the rights and well-being of children and youth. I'm first handing over to our one pre-recorded intervention from UNICEF, and then to the rest of the speakers. Thanks.
Excellencies, distinguished speakers and friends, it is an honor to join you today for this Youth Rise and Global Commission on Drug Policy side event during the Commission on Narcotic Drugs. Apologies for not being there with you in person. I'm Zainab Hijazi, UNICEF's global lead on mental health based in New York. At UNICEF, our work with adolescents is grounded in 3 principles: equity, participation, and a life course perspective. Adolescence is a pivotal stage of development. The brain is still rapidly maturing, identities are taking shape, and social environments begin to exert powerful influence. The support that young people receive during this period can shape their health, well-being, and opportunities for years to come. For this reason, responses to drug-related challenges affecting adolescents must be firmly rooted in youth-centered, health-led, and rights-based approaches. This means moving away from punitive responses and toward developmentally appropriate support that recognizes adolescents' evolving capacities while fully upholding their rights under the Convention on the Rights of the Child. UNICEF works with governments to strengthen child and adolescent responsive systems that prioritize prevention, early identification, and access to voluntary, evidence-informed care. This includes integrating age-appropriate substance use screening and brief interventions into primary healthcare, school health programs, and community platforms with strong safeguards for confidentiality and clear links to mental health services, given the high co-occurrence between mental health challenges and substance use. But a truly adolescent-centered response goes further. It means meaningfully engaging young people themselves, not only as beneficiaries of services, but as partners in shaping solutions. When young people's voices and lived experience inform policies and programs, services become more trusted, more accessible, and ultimately more effective. It also means investing in the environments that support adolescents to thrive, schools that build life skills and social emotional learning, parents and caregivers who are supported in their role, including adolescent mothers and families navigating substance use challenges, peers who reinforce positive norms, and communities that reduce stigma rather than deepen exclusion. Increasingly, digital platforms, when designed with appropriate safeguards, can also extend these protective spaces by providing reliable information, confidential early support, and pathways to care. Looking ahead to UNGASS +10 and beyond, one priority stands out clearly. Drug policies must consistently align with child rights and public health principles. The international drug control system must place the best interests of children and adolescents at its center. This requires a sustained shift from control toward care, supported by investments in prevention, community-based services, integrated mental health support, and rights respecting alternatives to punitive responses. Ultimately, safeguarding the next generation requires systems that are equipped and accountable to deliver care, dignity, and partnership with young people at every level. Let us act together with urgency and unity so that every child and every young person everywhere has the opportunity not only to be protected, but to truly thrive. Thank you so much, and I wish you a wonderful and productive event.
Thank you. And now we will hand over to a representative from the Czech Republic, Pavel Bem, and also representative of the Global Commission on Drug Policy.
Madam Chair, thank you very much for giving me the floor. My name is Pavel Bem. I'm a psychiatrist, psychotherapist, and family system therapist, and I very much enjoyed the presentation of Dr. Binder as well as Clara Holzinger, because these are exactly the fields I'm involved in for almost 40 years. Currently, I am nominated as a Czech drug tsar, or national drug coordinator, And somehow it's not for the first time. First time it was in early 90s when I had the opportunity to design the Czech drug or Czechoslovak drug strategy. That time I was a member of the youth, young generation. Currently, for the second time in this position, I am a member of senior population. And somehow that reflects and mirror the reality of Czech drug policy as far as the priorities are concerned. So we are focused at these, not only certainly, but at these two target populations, the youth on one side and the aging population of drug users with severe addictions and severe comorbidities as far as mental health is concerned. The question for me, and I'm not going to take too much time, what are the strategic thoughts behind the Czech drug policy? Certainly, we keep an eye on making sure that it's based on evidence and it's human rights oriented as well as harm reduction oriented, because the Czech Republic is not a so rich country, and we have really to make sure that all the invested means are effective. So we are looking at the cost effectiveness of cost-benefit approach. The national drug strategy in place in the Czech Republic ends next year, puts strong emphasis on prevention, treatment, and harm reduction in drug use, especially among youth. The Czech Republic systematically advances civil society engagement and anti-stigma efforts, as well as gender and age-sensitive approaches at both EU as well as UN levels. It's important for us that the human rights principles continue to be safeguarded and health remains in the center of drug policy, and the young people with lived experience should be included in the formation of drug policy. It's not easy to do it as far as, for example, children are concerned, but we are trying to do so. And the new action plan and drug policy, which is just now being prepared, is based on this strategy. We also look at the regulation of substances with lower risk, because we do not see too much benefits of all these prohibition approaches. I don't want to use the term war on drugs, because we saw such enormous stigmatization in our country that we are trying to prevent stigma, ensuring accessible services for young people. Finally, the Czech Republic has somehow championed these principles at EU level, and notably through Council conclusions on a human rights-based approach to drug policy adopted under its 2022 EU presidency. I would like finally to acknowledge the job which has been done for the last 15 years by Global Commission on Drug Policy, because I'm also a commissioner of Global Commission on Drug Policy, and I think that through the decent diplomacy and public awareness based on scientific evidence, we really reached the change since 2011 or 2012 when the Global Commission on Drug Policy has been constituted. So I'm very happy to be here and very happy just to share with you not only our experiences, but to learn from other countries. So congratulations. Thank you.
Thank you so much. Thank you so much, Pavel. I really appreciate it. We have only 10 minutes left, so if people can keep it to the 2 minutes, I'd really appreciate it. So the next, I'm going to hand over to Sally from the Office of the High Commissioner on Human Rights.
Thank you, and good afternoon, everyone. It's quite difficult to summarize on those two questions in 2 minutes, but I want to briefly outline some of the reports from our office, or just name them, so that I don't take up too much time. So the Office of the High Commissioner for Human Rights supports youth-centered and health-led and rights-based responses to drug-related challenges. And some of the reports that our office has been engaged with have been Human Rights Council reports from 2015 onwards. So I could name the acronyms, but I'm not going to. But I want to give a quote from one of the reports, which was former Secretary General Kofi Annan, and he said, "A criminal record for a young person for a minor drug offense can be a far greater threat to their well-being than occasional drug use." And certainly when I was listening to the presentations, it really resonated. That was 2015. Since then, there have been a number of other Human Rights Council reports, including one in 2018, another in 2023. And what I would really call on just in this meeting is to encourage, earlier this month, our office did send out a call for input on a forthcoming report, and the deadline is later this month. And so I'd really encourage and ask that one of the things that youth can do is not only to engage with the human rights mechanisms, including the CRC, which has been mentioned by our UNICEF colleagues, but also on this forthcoming report, which is on the implications of drug policies on the rights of women and girls. And I know that several partners in this room have probably received that invitation, but I'd be happy to circulate it as well. Thank you.
Thank you so much, Sally. I really appreciate it. I'm going to hand over straight away to Bojan from UNDP.
Thank you, Chair, and thanks to all the co-sponsors for organizing this important discussion. I think we saw from the presentation that there is some sort of systemic flaw of us thinking about youth as some sort of like mini adults. It's very... Oh, the mic, sorry. It's a flawed approach. So both at the policy level and from there to the programmatic level. So we have to acknowledge that adolescence and early adulthood, they come with distinct social, legal, and health vulnerabilities, and as it was mentioned, with evolving needs. And policies, unfortunately, in many cases, including drug policies, often overlook these realities, and we face barriers to prevention, to treatment, to harm reduction services, and exclusion of young people from adequate services. So at UNDP, we try to carefully listen to youth voices. For instance, when the outgoing Global AIDS strategy was designed, we organized the feedback from youth organizations as to how these services should be tailored, and what we heard completely did not correspond to what we expected to hear. So it was a very important learning process which informed the development of the Global AIDS strategy, the one that's ending this year, is that what I'm referring to. Another thing that we tried to do at UNDP in partnership with all UNAIDS co-sponsors and in partnership with youth organizations is to look into the recommendation of the Global Commission on HIV and the Law. They are by now almost 15 years old, so a lot has been done, for instance, in research around age of consent, but a lot remains to be done, and it does not always translate to adequate policy approach in many countries. So whenever we can, we support countries through policy advice and technical support how to reform these policies. And the third thing that I would like to mention, and this is connected to a big concern of mine and a big concern of the organization, this is the active engagement of youth organizations and networks in the discussion and in informing the whole global discourse and then national approaches. There is a growing concern about funding and support of such organizations. To give an example, there was an excellent initiative that was led by UNICEF. UNDP was one of the partners, that was called Legacy. And I believe Youth Rise was one of the members. So this organization, this network was providing youth-tailored resources with the active leading participation of organizations all around the world, I think over 200. on good approaches that are inclusive, and we lost the funding. So the project is put on pause, and it will be fantastic if this project is actually resurrected and catalyzed. So I just wanted to say that the international guidelines on human rights and drug policy that UNDP support, they reconcile the human rights framework with the drug control framework, and it will be very good for us to also look at the opportunities to integrate youth-sensitive responses in these reforms that are happening, that are being informed by these guidelines. So in conclusion, I just wanted to say that if we want to have health systems that truly support, as we say these days, prosperity, inclusion, and well-being, youth leadership cannot remain symbolic, and it needs real support. Thank you very much.
Thank you so much, Boyan. I really appreciate it. So now over to the International Federation of Medical Students Association.
Thank you so much for the side event and for inviting us. I'm Anna. I'm a medical student in Greece, and I'm here with the International Federation of Medical Students Associations. We're representing medical students from more than 120 countries. So what I wanted to stress with my presence here is the medical aspect, including, of course, the youth, because as future healthcare professionals, we see every day how the stigma is still there inside the hospitals and the health services, and there are gaps in our training that continue to prevent many youth people from actually reaching out to these services. So most of the solutions that young people have right now are community-based, but this can also not be reachable for some of them. And of course, there's different approach that needs to be done, including the medical sector. So one priority change for us would be the integration of stigma-free and youth-oriented training for healthcare professionals on substance use and harm reduction, and for the health workforce development. And for us to be equipped with evidence-based and non-judgmental care. I think this is very important, because also the approach counts. It's not only the information. We have the information all of the time, but we don't know how to approach these patients. So for us, as IFMS say, through initiatives and through being part of the UNODC Young Doctors Network, we try to empower young healthcare professionals to understand these topics and contribute in their countries and in their contexts to health-centered and evidence-informed responses to drug-related challenges. So as we approach now the 10-year review of the 2016 UNCA assess on drug and meaningful engagement with youth, I think is very present. You also mentioned it. So we are here, and we are grateful to be working with you and contribute in this sector. Thank you.
Thank you so much. I really appreciate it. And over to the Global Campus on Human Rights.
I see we only have a minute, so I'll try as quickly as possible. So what is the Global Campus of Human Rights? A network of around 100 universities with 8 regional master programs on human rights and democratization. And since 2019, we've been working very much on focusing on mainstreaming children's rights through our educational networks, but also specific projects that we've been doing all over the world, building capacities. These different 8 regional programs have also now a child rights officer, and we also conducted a project which is called the Child Leadership Team. And the Child Leadership Team is a group of children that are coming together in each of these regions, coordinated by their child rights officer, and also a youth advisory group, which are the children who grow older, so 18 to 24, which is still part of the whole sessions. And we're working with them to move away from this adult-led tokenistic forms of participation to more child-led processes where they decide really what they want to talk about and work on. So we have been now working with them for the past 5 years, and each region has now a child leadership team. And for our cooperation with the Transforming Drug Policy project, which was led by our side by Julia Runte and John Paul Amma, we have engaged with children in 6 out of the 8 regions of the world. At first, we did research also in the different regions, and then that moved towards specific sessions, online virtual sessions, about 3 that we did, to really listen to them and to hear what their wants and needs are in this relation. And I won't add anything extra in this because a lot has been said. But one thing was that across all regions, young people really endorsed harm reduction, evidence-based education, and compassionate communication as more effective approaches. And lastly, what's the most important is they welcomed and appreciated being able to speak their voice and be heard in the process. And this is exactly where it should start. It should start with the youth and with the children, and then move towards the policies and so forth. Thank you so much for listening.
That brings us to the end of this side event. I just want to take a minute to thank the co-sponsors, namely Australia, Czech Republic, Mexico, UNICEF, Office of the High Commissioner for Human Rights, UNDP, UNAIDS, International Federation for Medical Students Association, IDPC, UNAIDS, Input, Harm Reduction International, LEAP, Urinput, Release, SCOON, De Justicia, Elementa, EHRA, Correlation European Harm Reduction Network, Students for Sensible Drug Policy International, and the Global Campus for Human Rights. Thank you all, and thank you all for coming today. I really appreciate it. We can continue the discussion in the halls, but we're going to get kicked out of this room now. Thank you so much again. Bye.